Gynecomastia is the topic, and gynecomastia is essentially hypertrophy of the breast. And of course, we're talking about males. And for the most part, for most clinical vignettes, it's essentially normal. And in cases such as puberty, and it's given a name, it's essentially just physiologic gynecomastia. But in a small percentage of cases, it can be pathologic. Now, the main factor in gynecomastia that you need to remember is that you have an increase in estrogen, either effect or production. And there's a special name given to this. It's called hyperestrogenism. Very important to remember that. And that will creep up on licensing exams for sure. So let's talk about some of the pathologic reasons why somebody could have gynecomastia. Well, first of all, we're talking about men, because remember, in puberty and adolescence, it's normal. Some of the reasons, of course, include medications, in particular certain medications like steroids. Spironolactone is a known cause. And sometimes certain medications like anti-androgen drugs that are used, these medications can also cause gynecomastia. Now what I wanted to do is talk a little bit about some of the other causes, and instead of breaking it up into two categories that I present later on, one now and one later, I'll do it at the same time. So first what I'll do is talk about some of the causes, the pathologic causes of gynecomastia, and then I'll talk about what tests you would do to diagnose that. So if you have a patient who presents with any kind of signs of liver cirrhosis, this is the first category, an alcoholic for example, and he's got gynecomastia, then that's definitely one of the causes. So how would you diagnose that? Well, you'd first want to do some liver function tests. Now remember, these tests are not necessary if there's no secondary cause evident, but if there is, these are the tests that you would do. The next type of cause is an estrogen tumor. And if you are suspecting that, then you would order an estrogen level. The next type of cause is chronic kidney disease. And then, of course, you would order BUN, creatinine levels. Next one I'd like to talk about is malnutrition or undernutrition. And tests like an albumin level would help. Another cause is hypogonadism. And the type of tests you would order: testosterone level, and then LH, FSH, estradiol. And then the final type of secondary cause is a testicular tumor. And one test that's definitely is a human chorionic gonadotropin level, HCG. So keep those in mind. These tests are not ordered for physiologic gynecomastia. There's no test necessary for that. For example, an adolescent that's going through puberty. But if it's a man who's past his adolescence and he has any of these causes that you suspect, then definitely these tests would be appropriate. And some important red flags I want to mention. If a patient comes in and has any of these, then that kind of shows you that it's beyond just physiologic gynecomastia. It's actually worrisome, something that needs to be explored. Any hard or fixated swelling. The key word is fixated. If it's fixed, it's not movable, that's a red flag. Anything that's painful or tender to palpation. Any kind of associated nipple discharge. And also nipple retraction on physical exam. These are worrisome. Who knows, there might be a malignancy, but it definitely is something that should not be found in physiologic gynecomastia. So now we talk about the treatment. Well, for the most part, there is no treatment necessary. Physiologic, you just leave it alone. It resolves within 6 months to 2 years, as the child is going through puberty. But if it is, of course, a pathologic cause, then you need to treat the secondary cause, and whatever that is. It may just mean discontinuing the offending medication. Maybe there's a medication the patient is on that's causing it, or more elaborate treatment depending on the underlying disease that the patient has. So let's take a look at a few clinical vignettes, see what this looks like. A 15-year-old boy comes to the office for a physical exam before going off to summer camp. He says that he has a tender lump in his right breast that he noticed a couple months ago. He's very concerned because he's going off to a new camp, and he's worried that he's going to have to change clothes in front of other boys in his bunk. He thinks that the other boys are going to see it and make fun of his breast. There are tears streaming down his face as he tells you this. Physical exam shows a 1.5 centimeter tender palpable mass symmetrically distributed beneath the right areola. There is no discharge from the right nipple. The left breast is unremarkable. The remainder of the physical exam shows a small amount of dark curling pubic hair and open and closed comedones on his cheeks, forehead, and back. Most appropriate next step is, well, he's 15. He's got pubic hair. He's got some acne. He's got all the signs, essentially, of a boy going through puberty and adolescence. And this breast lump that he's describing is most likely due to puberty. So this is essentially just a case of physiologic gynecomastia. It affects, a large number, 50 to 60% of adolescent boys. And it usually goes away in a couple years as they phase out through their adolescent stage. Nothing is necessary, just reassurance. So just tell them that it's common and no further testing is necessary. Parents of a 7-year-old boy bring him to you for evaluation. They have noted bilateral breast development. There's no history of exogenous estrogen use. His vital signs are normal, including a regular heart rhythm at a rate of 88. He has otherwise been well and is on no medications. There is no history of ambiguous genitalia at birth. On examination, the testes are approximately 1 centimeter each bilaterally. Penis is small. Breast tissue is palpable bilaterally with discernible areola development. There are no adrenal masses. The boy is 40th percentile for height and weight. Which of the following do you recommend? Well, in contrast to a boy in puberty, breast development in boys before puberty is always a bit concerning. And you really want to search for some sort of estrogen exposure. Now, the question does say that there's no history of exogenous estrogen use. So in this patient, I would probably go searching for some endogenous estrogen secretion. And what I mean by endogenous is something that the body produces itself. So probably some sort of tumor, either an adrenal tumor or testicular tumor, something like that. So I would definitely begin the search for a estrogen secreting tumor. I think he's a little too young to be going through this. 7 is a bit young for physiologic gynecomastia that can be just ignored and have the patient reassured. So that's what I would definitely recommend, and that is indeed the correct answer. And then finally, a 14-year-old boy comes to the office because his breasts have recently become tender and slightly swollen. He's worried that he is undergoing feminization and will grow up to become a freak. Upon examination, a tender 2-centimeter mass is found to be palpable in the subareolar region of both breasts. Which of the following describes the best course of action? Well, let's go through these one at a time. Excises the mass by performing a subcutaneous mastectomy. Well, that's not indicated at any circumstance. Incise and drain the masses would be a bit extreme, I think. Treat the masses with topical steroids, that's never indicated. So the first 3 are essentially never indicated, really. Neither is D. Actually, these are long shot answers. I'm not very surprised they put those in there. The only time I would see any of this done is if you're concerned for some sort of breast cancer, but there's nothing in the clinical vignette that suggests that. This is just a simple case of a boy going through puberty who's developed some slightly swollen breasts that have become a little tender. There's nothing concerning in the clinical vignette. So the correct answer to this question is just E. Just leave the masses alone. Basically, he just has some physiologic gynecomastia, most likely because of increased estrogen stimulation of the breast tissue, and it's normal in a boy going through puberty.